I'm going to go ahead and admit the waiting room, if that's all right. And we can go ahead and get started with that. One second.
Okay, Jack, is everybody in?
Yes, they are.
All right, why don't we go ahead and start so we can start on time. So welcome everybody. Thank you for coming to this formal presentation of Basile Njei's thesis defense, Patterns of Acute Liver Injury and Post-Acute Liver Sequela of COVID-19. And I think those of us on the call, although you have quite the audience today, Basile, a lot of enthusiastic supporters. Basile has been with us for a number of years now, and we've really enjoyed working with him. And just to show his commitment to finishing this thing, even though he went off and did private practice for a couple of years, he came back and finished. And I think he gets extra points for that, quite honestly. Just to give you a quick summary of Basile's background. He did his fellowship in GI here at Yale University from the 2014 to 2017, and his residency in primary care at the University of Connecticut School of Medicine. He got a master's of public health and epidemiology and biostatistics from the University of Edinburgh. He spent 2 years as a gastroenterologist at UPMC in Western Maryland as a sidebar, and we welcome him back. And with that, I think that's quite sufficient. Basile, take over.
Thank you very much.
Oh, I'm sorry. Would everybody please mute themselves for Basile's presentation? There'll be time for questions at the end.
Thank you very much. Honorable members of my PhD advisory committee, all protocols duly respected, ladies and gentlemen, we'll adopt the following plan. We'll begin with the background, then talk about some specific aims, our methods overall, results by specific aims, and then we'll conclude. In December 2019, SARS-CoV-2, an RNA virus, was first reported in humans in Wuhan, China. SARS-CoV-2 infection resulting in COVID-19 remains a global public health challenge. According to the World Health Organization, COVID-19 has affected more than 500 million individuals and caused more than 15 million deaths worldwide. In the United States, more than 80 million people have been diagnosed with COVID-19, with almost 1 million cumulative deaths attributed to complications of COVID-19. Initially considered a respiratory illness, COVID-19 is now recognized to affect multiple organ systems, including the lungs, the heart, the brain, endothelium, kidney, and the liver. The liver is of importance to us today. How does SARS-CoV-2 cause liver injury? It does so by 2 main mechanisms. It can do so directly or indirectly. Directly, what happens? You can see on the figure, this is the virus itself, the SARS-CoV-2 virus, and it has spike proteins on it. These spike proteins are able to bind to ACE2 receptors. These receptors are found on hepatocytes, these are liver cells, or cholangiocytes, which are bile duct cells. Once the virus is able to bind to these ACE2 receptors, it gains entry into these cells, leading to viral replication and can cause direct injury. Indirectly, in the setting of severe inflammation, the virus is able to activate immune cells at the level of the lung epithelium. These cells include T cells, macrophages, neutrophils, and these can lead to a cytokine storm. This can then lead to liver injury indirectly. Both in vivo and in vitro studies have demonstrated the hepatotropism of SARS-CoV-2 infection. In studies looking at hepatostoma cell lines, using electron microscopy, the virus, as well as its spike protein, has been identified within hepatocytes, suggesting that injury can be at the level of the hepatocytes, as well as cholangiocytes too. In organoid models, similar to what we presented in the previous slide, the virus can be seen with the spike proteins, binding to ACE receptors, and how it gains entry into the cells. Please permit me to mention that most of the ACE2 receptors are found in cholangiocytes, more than hepatocytes. And for this reason, some people believe that SARS-CoV-2 infection is more of a biliary disease than a hepatocyte-related disease. In studies looking at human liver, so in gene expression studies, the ACE2 gene has been shown in cholangiocytes and in hepatocytes. So the pale blue dots you see right here are the cholangiocytes, while the pale red dots you see are the hepatocytes. The deep red dots you see are the ACE2 genes being expressed. You can see that within hepatocytes, you can only count about 5 of them. While in the cholangiocytes, there's so many of the ACE2 gene. Again, this supports the hypothesis that liver injury in patients with COVID-19 may be a cholestatic disease compared to a hepatocellular disease. In histological studies, looking at livers of deceased patients during the COVID-19 pandemic, the virus was seen within the hepatocytes, actively replicating in cholangiocytes, but also there's been portal fibrosis shown, hepatic steatosis, mitochondrial dysfunction and apoptosis, as well as microvascular thrombosis. All this point to a multifactorial etiology of liver injury in COVID-19. So overall, in terms of the pathogenesis of liver injury in COVID-19, we could have a direct injurious effect of the virus on hepatocholangiocytes, as earlier mentioned. You can have a cytokine or immune-mediated liver damage in the case of severe inflammation. You could have systemic inflammation, hypoxia and ischemia, as well as drug hepatotoxicity as the cause of liver injury. Many studies have been done on this subject, but so far, there have been case reports, case series, and small cohort studies. In most of these studies, the elevations of AST and ALT have ranged from 14 to 83%, so they've varied widely, and most of the elevations suggest hepatocellular injury. It's worth noting that there is an AST predominant aminotransferase elevation commonly reported, wherein the AST is predominantly higher than the ALT. In a small population of about 3%, there is a peak in alkaline phosphatase levels of greater than 3 times the upper limit of normal, suggesting severe cholestatic injury. This has been termed COVID-associated cholangiopathy. What is the prognosis significance of elevated liver tests? That's the common question. Most of the studies have reported mixed results on the association between AST and ALT elevations and liver complications or mortality. Some of these studies have shown that AST levels positively correlate with levels of ALT, but not with markers of muscle breakdown, such as creatinine kinase. This would support the fact that liver test elevations might indicate true liver injury and is not a result of muscle breakdown, which can be seen in COVID-19. In a study at Yale University Hospital by Chu and collaborators, there was no association between AST levels greater than 5 times the upper limit of normal and markers suggestive of hepatic dysfunction. In a small study by Faruqi and collaborators, looking at patients with COVID-associated cholangiopathy, 5 out of the 12 patients eventually had hepatic dysfunction and had complications related to liver disease. So what's the rationale? So as results of long-haul COVID-19 suggest post-acute lung and cardiac complications, little has been reported about post-acute liver outcomes after COVID-19. The best of our knowledge, there are no nationwide large studies evaluating post-acute liver sequelae of COVID-19. The objectives of this dissertation and our study were to characterize the patterns of severe acute liver injury, hepatocellular, cholestatic, or mixed, and to determine the interaction of these patterns with liver-related clinical outcomes. To achieve the objective of this dissertation, the following specific aims were pursued. Aim 1, to determine the incidence rates of common patterns of severe acute liver injury after COVID-19 diagnosis in patients with or without pre-existing chronic liver disease. We hypothesized that the hepatocellular pattern of severe acute liver injury is the most common pattern of severe acute liver injury after SARS-CoV-2 infection. We also hypothesized that patients with pre-existing chronic liver disease prior to SARS-CoV-2 infection are more likely to develop acute liver injury compared to those without pre-existing chronic liver disease after adjustment for COVID-19 severity. The reason for this rationale is based on studies in the era preceding COVID-19 that found increased ACE2 gene expression in patients with pre-existing chronic liver disease compared to those without pre-existing chronic liver disease. In fact, a greater than 30-fold increase in ACE2 expression in the liver of patients with cirrhosis compared to those without cirrhosis has been reported. Also important is that patients with pre-existing chronic liver disease are more likely to have an increase in baseline endotoxemia and cytokine production that can lead to an exaggerated inflammatory response in the setting of SARS-CoV-2 infection. Aim 2, to determine the association between patterns of severe acute liver injury after COVID-19 diagnosis and incident hepatic dysfunction. We hypothesized that SARS-CoV-2 infected patients with severe acute liver injury are more likely to develop incident hepatic dysfunction compared to those without severe acute liver injury, even after adjustment for COVID-19 severity and pre-existing chronic liver disease. We also hypothesized that SARS-CoV-2 infected patients with a mixed pattern of severe acute liver injury are more likely to develop incident hepatic dysfunction compared to those with an isolated hepatocellular or cholestatic pattern. The reason for this rationale is based on studies that have shown gene expression levels for ACE2 in both cholangiocytes and hepatocytes. It is therefore reasonable to assume an additive effect of injury in patients with both hepatocellular and cholestatic injury after SARS-CoV-2 infection. Aim 3, to determine the association between patterns of severe acute liver injury after COVID-19 diagnosis and incident hepatic decompensation. We hypothesized that SARS-CoV-2 infected patients with severe acute liver injury are more likely to develop incident hepatic decompensation compared to those without acute liver injury, even after adjustment for COVID-19 severity and pre-existing chronic liver disease. We also hypothesized that the isolated AST predominant hepatocellular pattern of severe acute liver injury may be less likely to be associated with hepatic decompensation. The rationale for this is that prior studies suggest that an increase in AST levels could be associated with concomitant events common in COVID-19, such as ischemia, medication use, hyperinflammatory states, and hypercoagulable states. Therefore, the isolated AST predominant hepatocellular pattern of acute liver injury may be secondary to other insults, such as ischemia or systemic inflammation, and does not suggest simultaneous cholestatic injury, as would be expected if SARS-CoV-2 led to cytopathic liver injury. To study the patterns and incidence of liver injury in patients with COVID-19, a retrospective cohort study was conducted among patients with a positive polymerase chain reaction or antigen test for SARS-CoV-2. For data resources, we used the VA 2020 national cohort, which includes all veterans alive in 2020 in the VA health system. Data we used included dispensed prescriptions, outpatient and hospital laboratory results, outpatient and hospital diagnosis, and date of mortality. We included patients diagnosed with COVID-19 from March 2020 through October 2021. We excluded patients over the age of 100, patients on warfarin, as this can lead to coagulopathy, patients with prevalent severe acute liver injury, and patients with hepatic dysfunction or hepatic decompensation before COVID-19 diagnosis. In one outcome. To determine the full spectrum of liver injury events in COVID-19 positive patients, 3 incident liver injury pattern outcomes were examined. The hepatocellular pattern, defined as incident inpatient or outpatient peak AST level greater than 5 times the upper limit of normal. And we included an ALT greater than 40 to exclude AST leaked by muscle, as earlier mentioned in the beginning. Within the first 30 days after a positive SARS-CoV-2 test, the cholestatic pattern was defined as incident inpatient or outpatient peak alkaline phosphatase greater than 3 times the upper limit of normal within the first 30 days after a positive SARS-CoV-2 test. The mixed pattern involved patients who had both the hepatocellular pattern of injury and cholestatic patterns of injury. M2 outcome. Our M2 outcome was hepatic dysfunction. We defined hepatic dysfunction as outpatient or hospital results of INR greater than 1.5 of anticoagulation therapy, plus a total bilirubin of greater than 2.4. Both abnormalities had to be present within 30 days of each other. And our use of this definition for hepatic dysfunction indicates liver insufficiency. M3 outcome, hepatic decompensation. We define hepatic decompensation based on ICD codes, including esophageal variceal bleeding, spontaneous bacterial peritonitis and ascites. And our definitions included 1 hospital discharge diagnosis, principal or contributory, or 2 or more outpatient diagnoses recorded within 1 year. Patient follow-up. We begin with the patient who tests positive with COVID-19. And again, we included patients from March 2nd, 2020 to October 19, 2021. Our index date was the date of the first positive SARS-CoV-2 test. And this indicated start of follow-up. At baseline, or as baseline, we used closest labs in the previous 2 years prior or 14 days prior to the index date, so within two years. The reason for using 14 days or excluding 14 days prior to the index date was because some patients might present after they have already been infected and already been symptomatic. So keeping a window of 14 days would exclude these patients who were already infected. Within 30 days of diagnosis, some patients may develop severe acute liver injury. These patients may progress to develop the event, which is hepatic dysfunction or hepatic decompensation. Some patients might not develop severe liver injury, but progress to develop the event at some point during our follow-up interval. Irrespective, we censored at the end when patients started warfarin, died, or at the end of the study, which was March 31st, 2022. How did we define pre-existing chronic liver disease, which was very important to us? Using established methods, patients were classified with chronic liver disease if they had hepatitis C virus RNA positivity or genotype indicative of this, if they had laboratory evidence of active hepatitis B, had undiagnosed liver disease, or had ICD-9 or 10 codes for chronic liver disease. We also included patients with a fibrosis 4 index of greater than 1.45. I would like to mention that the fibrosis 4 index, or the FIB4 index, is calculated from the age, the AST, the platelet count, and ALT. Our use of FIB4 greater than 1.45 as an additional chronic liver disease criterion helps to minimize likelihood of misclassification of chronic liver disease status when documentation of viral hepatitis laboratory test or chronic liver disease diagnostic codes were absent. What is the VICO-ACUD index? This is an important measure of COVID-19 severity. The VICO-ACUD index is an excellent measure of COVID-19 severity and estimates the probability of death within 30 days of COVID-19 diagnosis. This index was developed by members of our team and Dr. King at West Haven VA and Yale University, and this has been widely validated as well. The VICO-ACUD index discriminated 30-day mortality in development and validation with an area under the curve of 0.89. Also important, the VICO-ACUD index showed nearly identical accuracy when extended to mother survival the first year after COVID-19 infection. The index is calculated from chronic conditions at the date of positive COVID-19 testing, demographic data, the Charlson index, which includes variables such as diabetes, pulmonary and cardiovascular disease, hypertension, and body mass index as well. But in addition, this index also includes vital sign parameters and laboratory tests that were collected within the first 30 days of COVID-19 diagnosis. Our statistical analysis. We calculated incidence rates as events per 1,000 person years of outcomes with 95% confidence intervals for patients in each pattern group. Cumulative incidence rates were estimated for each outcome of interest, and our results were stratified by pre-existing chronic liver disease status. We carried out pairwise comparisons of outcomes with unadjusted and adjusted Cox proportional hazard analysis. All statistical analyses were performed with SAS, and study findings were reported as per strengthening the reporting of observational studies in epidemiology guidelines. And results. After applying exclusion criteria, there were over 170,000 patients in the analytic sample. Of these patients, the median age was 60. The majority of our patients were males, as expected, as we're using the veteran affairs data. And our cohort was predominantly made of non-Hispanic or Latino whites. The figure displays the histogram of the percentage of severe acute liver injury events by pattern of injury. On the y-axis, you see the percentage of the severe acute liver injury events, and on the x-axis is the time from COVID-19 diagnosis. We have hypothesized that the hepatocellular pattern of injury is the most common pattern of injury in COVID-19. Our results confirmed our hypothesis. Most of the severe liver injury events were from hepatocellular injury compared to the other patterns. You can see that. Also important is that most of the severe liver injury events occurred within the first 2 weeks of COVID-19 diagnosis and slowly dissipated over time. This was true irrespective of the pattern of liver injury. The table shows the incidence rates of severe liver injury by pattern. And the important finding on this table is that patients with pre-existing chronic liver disease had higher rates of incident severe liver injury. This was true independent of the pattern of injury. In our unadjusted and adjusted analysis, we found as hypothesized that patients with pre-existing chronic liver disease were more likely to have severe liver injury compared to patients with no pre-existing chronic liver disease. And this was true even after adjustment for COVID-19 severity using the VACO-ACUID index. The figures illustrate the cumulative incidence plots for incidence severe liver injury by pattern. And again, just want to show you that the blue lines represent patients with pre-existing chronic liver disease, and the red dotted lines indicate patients without pre-existing chronic liver disease. And you can see that patients with pre-existing chronic liver disease have a higher cumulative incidence, and you can see the difference compared to those without pre-existing chronic liver disease. These stay true irrespective of the pattern of injury. Aim 2. The table shows incident rates of hepatic dysfunction by pattern of liver injury. Permit me present to you an important clinical finding on this table. We found that patients with a mixed pattern of liver injury had a 25% absolute risk of hepatic dysfunction after COVID-19 diagnosis. In addition, these patients with a mixed pattern were 10 times more likely to develop hepatic dysfunction compared to those with no severe liver injury. The importance here is not that there is an increase, but the magnitude of the increase that we want to emphasize. In our unadjusted and adjusted analysis, as hypothesized, we found that patients who had severe liver injury, irrespective of the pattern of injury, were more likely to have hepatic dysfunction after COVID-19 diagnosis compared to those with no severe liver injury. And this was true even after adjustment for COVID-19 severity and COVID-19 severity plus pre-existing chronic liver disease. That made me to take time to present this slide because this is the most important slide in this presentation. We have hypothesized that patients with a mixed pattern of injury are likely or are more likely to have hepatic dysfunction because of an additive effect. Interestingly, we found a synergistic effect. The green line indicates the patients with a mixed pattern of injury. The blue line, hepatocellular injury, and the dotted red, cholestatic. The difference between addition and synergism is that in a synergistic effect, it's not just adding A and B together, but putting A and B to produce an effect that is much, much higher than just adding the sum of those two. In fact, almost an exponential effect. This is not a common finding in epidemiology. And this is an interesting finding in this study, which we'll discuss later on. We stratified our results by pre-existing chronic liver disease status. So in a subgroup looking only at patients with pre-existing chronic liver disease, we found similar results with patients with severe acute liver injury, more likely to have hepatic dysfunction. And this was true after adjustments for COVID-19 severity. We had similar results again when we only looked at patients with no pre-existing chronic liver disease, but for cholestatic injury, the results did not meet statistical significance. And we believe this is probably related to the sample size of these patients. Aim 3. This table looks at the incidence rates of hepatic decompensation in patients with COVID-19. And again, I want to talk about the mixed pattern because they stand out. Patients with a mixed pattern had a 10% absolute risk of hepatic decompensation. This is of clinical significance, meaning if you have 10 patients with a mixed pattern, at least one of them may develop hepatic decompensation. This is significant clinically. In our unadjusted and adjusted analysis, we found as hypothesized that patients with a hepatocellular pattern of injury were not more likely than patients without severe acute liver injury to develop hepatic decompensation. That wasn't the case for patients with the cholestatic and mixed patterns. Again, this is our beautiful plot. And you can see the green line is the mixed pattern, and you can still see the synergistic effect even in the setting of hepatic decompensation. But more importantly, on this slide, you can see that in patients with the hepatocellular pattern, which is the blue line, there wasn't a significant difference in terms of hepatic decompensation compared to those with no acute liver injury. Patients with cholestatic liver injury, however, had a significant difference. In stratified analysis, again, by pre-existing liver disease, we found similar results. And in subgroup analysis, only looking at patients with no pre-existing liver disease, the mixed pattern of injury, despite the smaller number of events, remains statistically significant and important. These figures show our sensitivity analysis. And what we did in the sensitivity analysis was we changed the definition of the hepatocellular pattern of injury and looked at an ALT predominant pattern. So instead of looking at AST only, predominantly, we looked at ALT. And irrespective of looking at ALT greater than 200 and different AST cutoffs, so in this figure, we only looked at ALT greater than 200, and the ALT was predominantly higher than the AST. While in this, we looked at ALT greater than 200, and the AST was less than 200. However, irrespective of the definitions of the hepatocellular pattern of injury, our results did not change significantly. Our results suggest that severe acute liver injury with cholestatic and the mixed patterns may be associated with worse liver prognosis in patients with COVID-19 compared to the hepatocellular pattern of injury. Our study has several limitations. We did not have histopathology confirmation of our clinical outcomes in the study. We did not assess the etiology of severe acute liver injury. And so we are unable to make causal inferences as well. We had concerns for confounding by indication if we looked at treatment. And so we did not assess the impact of treatment in this specific study. And also because we had multiple comparison groups to compare. We did not look at vaccination and the type of SARS-CoV-2 variant or recurrent infections and how they impacted our results. Despite these limitations, our study has several strengths. The large sample size of more than 170,000 patients permitted us to study rare events, such as hepatic decompensation, that could occur in the setting of COVID-19. Because we used both inpatient and outpatient data, we've reduced the risk of selection bias compared to most other studies that only looked at hospitalized patients. Also important, we had a lower risk of collider bias. And collider bias is a situation where both COVID-19 and comorbidities such as liver disease can lead to hospitalization, resulting in a distorted association between these comorbidities and COVID-19 when the analysis includes only hospitalized patients. In summary, this dissertation investigated the risk of COVID-19 associated severe acute liver injury, looked at hepatic dysfunction and hepatic decompensation among more than 170,000 patients diagnosed with COVID-19 within the VA. Our results revealed that the most common pattern of severe acute liver injury in COVID-19 is the isolated hepatocellular pattern. That pre-existing chronic liver disease is associated with higher rates of severe acute liver injury, independent of COVID-19 severity. That the hepatocellular and cholestatic liver injuries we see in COVID-19 have a synergistic effect on incident hepatic dysfunction and decompensation. That the mixed pattern of severe acute liver injury in COVID-19 is associated with incident hepatic dysfunction and decompensation, even after adjustments for COVID-19 severity and pre-existing chronic liver disease. That the mixed pattern is a high-risk subphenotype with an absolute risk of hepatic dysfunction of about 25% and an absolute risk of hepatic decompensation of 10% within 1 year after COVID-19 diagnosis. Finally, that the isolated AST predominant hepatocellular pattern of severe acute liver injury in COVID-19 is less likely to be associated with hepatic decompensation. Why are these results important? Our study has biological, clinical, and public health implications. From a biological perspective, our study represents the strongest indirect evidence today to support COVID-19 hepatocholangiopathy and paves the way for further research. Further studies are needed to better investigate the pathobiology of patients with the mixed patterns of severe acute liver injury, and also to determine whether this hepatocholangiopathy resolves or persists as a chronic hepatocholangiopathic disease. From a clinical perspective, the patterns of acute liver injury may facilitate risk stratification of COVID-19 patients in the clinic setting. From a public health perspective, patients with severe acute liver injury after COVID-19, especially the mixed pattern, are at risk group for hepatic dysfunction and decompensation, and they may require follow-up inpatient and outpatient, and may also benefit from vaccination. In Africa, we say that if you want to go fast, go alone. But if you want to go far, go together. I've been able to go this far in my life and career because of the support of several people. I would like to acknowledge my amazing and wonderful PhD advisory committee, Professors Amy Justice, Joseph Lim, Tamar Chadi, and Vincent Lure. Sincere thank you to the VAX team. Gente, thank you for giving me a second chance. To Joe King, thank you. You and your team created the Vickery Acute Index, which we're able to use to measure COVID-19 severity, and facilitated this project. To Angela Conchofi, thank you for always being there, working on my schedule. And you know already, you're my favorite person. To Leslie, Chris, Kershaw, Farah, and the entire team, thank you for always being there to help me with epidemiology ideas, as well as life overall and advice in academia. To the Yale Investigative Medicine Program, Jean Shapiro and Joe Kraft, thank you. Thank you to the Yale Center of Clinical Investigation that offered me the TL1 grant, which sponsored my thesis during the last year completion. Of course, to the Yale Digestive Disease Fellowship Program, to all the faculty and fellows, my co-fellows when I was a fellow, as a clinical fellow, thank you. Thank you to Michael Nathanson, who offered me an NIH T32 grant that helped me to train as a clinical gastroenterologist, as well as an investigative hepatology fellow during my training. Plus, at the end of my training, thank you, Michael Nathanson, again, for offering me a position as adjunct assistant professor when I was away. And thank you, Lauren Lane, for extending this appointment, even when I was away. To my teachers from nursery school, elementary school, high school, back in Cameroon, medical school, my tutors and Qs, I see some of you, thank you. To my colleagues, thank you. To my friends and my families, thank you very much. To my mom, give me a minute. Give me a minute. To my dad, thank you. Thank you very much. That's the end.
Thank you, Basile. That was a wonderful presentation. I'm going to start out with the questions, but then I think there will be lots of other questions from people. If folks could use the chat to ask the questions, that would be really wonderful. You covered a lot of ground and have some exciting findings. My question to you is, what is the next piece of information you would most like to have about these people? Is it the pathology biopsies? Is it additional laboratory data? If you had, money right now in a grant to follow up this work, what would be the emphasis that you would want to follow?
So I think the first thing is to actually look at these people in detail And I think the first step would maybe to do a chat review and actually find out who these people are. And that will involve looking at, in detail at the other comorbidities that maybe we didn't identify just by using codes. I think I would really like to look at pathology if available. We might not have all of that, but especially in the early phases of the disease, we might have some of that. Again, like you mentioned, the pathobiology is very important because this is a finding that you don't come across every day in medicine, right? To find a situation where you have two diseases or two levels of injury leading to a synergistic effect, you want to find out why, what really happens. It's not barely addition, there's something more to this. And we really want to know why. And there's so many hypotheses. And I believe that after this, a lot of people are also going to come out with explanations and suggestions. But I think that taking a closer look to, in this population, looking at pathology, which I think is very important, and also just following them over a long period of time. Like, okay, there's a group of people, I want to see what happens in 2 years or in 3 years and all of that. I think that will be my focus.
Okay, thank you. Other questions? I see that there's one from Dr. Nathanson. Great to see you again. Happy that you persevered to carry out this impressive work. Do you have any insight about whether alcohol use relates to these results? Great question.
Yes, yeah, thank you so much, Dr. Nathanson. It's a very important question. And so, although we haven't looked at this further, we suspect that this might play a big role for two reasons. The first reason will be that, of course, during the pandemic itself, there was an increase in alcohol use, as we know. Secondly, because we know that alcohol use on its own increases the number of ACE2 receptors in the liver, and that could increase the level of injury. But also important, when we look at the hepatic decompensation events, more than 80% of them had developed ascites. And we know that in alcoholics, it's not unusual to have hepatic decompensation, which sometimes could even be reversible just with alcohol use. So we suspect that this population might be an interesting subpopulation to better look at, and that alcohol use might be playing a strong role. And not to forget that alcohol and COVID-19 may likely be a toxic cocktail based on the mechanisms of actions. So I think that is highly possible.
Okay, thank you. Other questions? So my comments, another reason is that patients with alcoholic hepatitis with the cholestatic component have a worse outcome. And then Dr. Chu says, how do you compute the VACO acute index from the various mentioned features?
Yeah. So this involves a lot of statistical work, okay, and some of which, I would have to defer to the original, creators of this. So I don't want to speak too much for them. But it's basic statistics where we use regression analysis to predict certain outcomes. So they developed this score using several variables, as mentioned. So most of them are, comorbidity diseases, laboratory tests, and vital signs. They also did an updated analysis in which, as time goes by, once patients had a different laboratory test or different vital sign, this was replaced in the model so that the results were more up to date. And they looked at different predictive models to predict, to develop the score. So I wouldn't get into detail just because it's a little bit more scientific and more statistical. But I would say that this was, developed and validated. Hasn't only been studied in the VA population, it's also been studied in the VA in tertiary centers such as Yale New Haven Hospital as well, and other places. So again, we say thank you to those who developed this.
So Basile, I think one more question, and then we may have to switch to the asking the rest of the group to step aside so we can have an internal conversation. And that is, well, actually, there are two more questions. Let's see. Are there insights into the difference of effects by sex, and is there a rationale for a higher slope of decompensation than hepatic dysfunction? Thank you, and congrats on your great presentation. So sexual, are there differences by sex, and
yes.
evidence rationale for a higher slope in decompensation?
Yeah, so of course we're dealing with the VA, 95% we have males, okay. But we adjusted for the differences in sex in the model itself. The slopes are different for dysfunction and decompensation because they're two different clinical outcomes. You would expect that for decompensation, the slope might be even lower because it takes a longer time to develop decompensation, and not everybody who has hepatic dysfunction is going to have decompensation. So we don't expect the same slopes as well. So I'm not sure if that answered your question, but that is some of the information I can produce. Thank you.
Okay, well, I think there are some more questions in the chat that you might want to look at, especially before you think about submitting to the journals. But I think at this point, we need to switch to the internal review. So I would ask the visitors to sign off, and we will go to the internal review. Thank you.
Thank you. Thank you so much.
That includes general faculty, yes. It's just the thesis committee at this point. Jack, do you want to maybe just sign out the other people?
I'm removing a few folks who might have left the computer.
Okay. Okay, I think this is the group, right, Jack?
Looks right.
Okay.
And we've got Joe Lim. Yes, that's okay, perfect. I'm used to full names.
But Basile goes into a waiting room, right?
Well, no. First, there's a period.
Oh yeah, okay, right. I'm sorry.
And then he goes into the waiting room.
Yeah, questions here.
So, does anyone in this group have additional questions for Basile before he goes into the waiting room and we discuss?
So I just have a question that made me think, because, Michael always has great observations, and he's like, well, cholestatic injury is bad in alcohol, but come to think of it, cholestatic injury is bad in everything, in DILI and COVID and alcohol. And, the picture that you showed at the beginning of your presentation with the distribution of the ACE receptors made me think that you ought to collaborate with a biologist who could look at cell signaling. Maybe COVID's telling us something that could be canonical there. I just thought it was very interesting because, you start to think about these things and then you see patterns emerging. So beautiful job, Basile, really nicely done.
Thank you. Yeah, I know Dr. Nathanson has done a lot on calcium channel signaling and cholestatic liver disease. And it might be interesting to look at that actually. It might be very interesting.
Any other questions for Basile before we go to the private session? All right, well, if not, then Jack, do you want to put Basile into the wait room?
Will do. Basile, I'll let you back in once the committee has deliberated. I'm also going to end the recording now.